Hello, everybody. Good afternoon, and welcome to our July Act and Learn webinar, Fighting for Medicaid Expansion Amidst Funding Cuts. So I will go ahead and introduce myself. My name is Jessica Ensley. I use she, her pronouns. I'm the senior, what's my title? Senior Vice President of Outreach here at Repro Action, and I'm based in Washington, D.C. And I will pass it over to my co-host to introduce herself.
Hi everyone, I'm Ani Bennett-Fradkin. I use she, her pronouns. I'm the Archival Research Coordinator here at Repro Action, and I'm based out of Los Angeles.
Awesome. So here is an overview of our agenda for today. I will introduce the organization before passing it over to Ani to go into today's topic. And then we have a lovely set of panelists for you, and then we'll get into next steps in our Q&A. If at any point while we're going through this topic you have questions for the panelists, please enter that into the questions section of GoTo, and we will address those at the end. So to start us off, Repro Action, we lead bold action to increase access to abortion and advance reproductive justice. We are known for our left flank analysis, our willingness to hold folks on all sides accountable, whether they be allies or opposition, and our commitment to nonviolent direct action. And I do want to make a special note that we are a 501c3 organization. We do not campaign for or take an organizational stance on any pending legislation, though we do acknowledge there are lobbying campaigns for Medicaid expansion, especially at the state level across the country. So I will go ahead and pass it over to Ani.
Thanks, Jessica. So Medicaid is hugely significant right now, but it can be a little bit difficult to grasp everything that Medicaid entails. So I want to start with just a baseline. What is Medicaid? Medicaid is a public program that provides health insurance for folks who are otherwise unable to obtain it. It's funded jointly by federal and state governments, and there are 56 Medicaid programs. So all 50 states, DC, and then the 5 US territories have their own Medicaid programs. The federal government determines what must be covered under Medicaid, but states determine their eligibility and coverage requirements beyond that. 40 states and DC have extended Medicaid eligibility under the Affordable Care Act. These are expansion states, and other states haven't. Wyoming, Kansas, Texas, Wisconsin, Tennessee, South Carolina, Mississippi, Alabama, Georgia, and Florida. These are our non-expansion states. As you can see, Southerners are most affected by non-expansion. When we get specifically into HR 1, there is some language that determines or is determined by whether you're in an expansion state or a non-expansion state. So please pay attention to that, especially if you're in one of those 10 states. The impact of Medicaid. Medicaid insures 71.3 million people as of March 2025. That includes 4 in 10 children in the United States, including 8 in 10 children in poverty, and nearly half of children with special health care needs. 1 in 6 adults in the United States are insured under Medicaid, including 1 in 4 adults with disabilities and 5 in 8 nursing home residents. Specifically in the context of reproductive health care, Medicaid covers roughly 40% of births in the United States. 40% of non-elderly adults with HIV are enrolled in Medicaid. To be clear, there are already strict requirements for abortion care under Medicaid due to the Hyde Amendment, which passed in 1977 and determined that there can be no federal funding of abortions, with the exceptions of rape, incest, and life endangerment. 19 states, however, do direct state Medicaid funds to help cover abortion costs and support access for historically marginalized and underserved communities. Based on a 2021 to 2022 Guttmacher report, 71% of folks seeking abortion care in these 19 states paid $0 for their abortion care. Also, 70% of Black pregnant people, 66% of Latina pregnant people, 78% of pregnant people in the lowest income group, and 75% of people receiving second trimester abortions relied on that state Medicaid fund in those 19 states to help cover their care. So looking at the large-scale attacks on Medicaid recently, the first one that I'm going to talk about is Medina versus Planned Parenthood South Atlantic. On June 26, the Supreme Court ruled that South Carolinians enrolled in Medicaid cannot choose to use Planned Parenthood as their service provider under the free choice of provider provision in federal Medicaid law. Now, South Carolina's Medicaid program already bars clinics that provide abortion care due to a 2018 executive order This was critical for the Medina v. Planned Parenthood decision. The Supreme Court ruled 6-3 that the free choice of provider provision does not confer individual rights, but rather mandates that people have a choice of provider. So that is to say that for groups willing to participate in Medicaid, folks may still not be able, like Planned Parenthood, to choose them as their provider, despite being able to have a choice of provider. This doesn't just block abortion care, it also reduces access to contraception, preventative care, STI testing, treatment, and more. Currently, Medina v. Planned Parenthood South Atlantic only applies to South Carolina, but other states that have barred or challenged Planned Parenthood's participation in Medicaid are expected to follow suit with the new precedent. Again, Southerners will bear the brunt of this care inequity. 14 states have already challenged or attempted to challenge Planned Parenthood's participation in Medicaid, and these are largely in the South. The other large-scale attack that we've been seeing recently on Medicaid is H.R. 1, also known as the One Big Beautiful Bill Act, which was signed into law on July 4th. H.R. 1 cuts $1 trillion in federal spending for Medicaid and the Children's Health Insurance Program, or CHIP. 11.8 million are expected to lose their health care coverage, and hospital and clinic closures in rural communities are expected, further exacerbating care deserts. The defund provision specifically determines that prohibited entities are barred from receiving Medicaid for 1 year. This was originally 10 years, but the Senate parliamentarian reduced it. In order to be considered a prohibited entity, you must meet all 4 of the following requirements. You must be 501c3 tax exempt and an essential community provider that is primarily engaged in family planning services, reproductive health, and related medical care, and provide abortions beyond height exceptions, and have received over $800,000 in Medicaid funding in the 2023 fiscal year. This, in a roundabout way, very specifically targets Planned Parenthood, but there are a lot of other clinics that will meet these criteria and will face losing their funding as a result. Planned Parenthood says that 1.1 million of its 2.1 million annual patients could lose access to care, and there are ongoing efforts to challenge this. Planned Parenthood is suing the administration, so that Kennedy and PPFA Inc. et al. Versus Kennedy et al. Is Robert F. Kennedy at the Department of Health and Human Services. U.S. District Judge in Boston, Indira Talwani, granted a preliminary injunction on July 7th for 14 days, blocking enforcement of this defund provision. And just this morning, a federal judge has replaced that injunction and continued to block enforcement. And Jessica, I will pass it to you to get us started on our panel.
Thank you so much, Ani, for that overview. So I would like to introduce our first panelist, Amanda Spriggs-Reed. Amanda is an Equal Justice Works Fellow with Women Enabled International. Amanda's EJW project at WEI advocates for abortion access for disabled people through amicus briefs and impact litigation, technical guidance on disability justice issues for abortion care professionals, and education resources on reproductive justice for disability advocates. Her project work so far has included filing United States Supreme Court amicus briefs, conducting trainings on the intersections of reproductive justice and disability justice, and a report on providing accessible abortion services to disabled clients. Amanda received her JD from Wake Forest University School of Law in 2023, where she was awarded the Smith Anderson Pro Bono Award for Exceptional Service and the Miriam E. Mickey Felsenberg Award, recognizing exceptional leadership in the area of social justice. Amanda, thank you so much for joining us today.
I'm so happy to be joining. Thank you so much for inviting me.
Of course. My first question for you is, what factors should we consider when thinking holistically about equitable access to reproductive health care?
Yeah, so I think that in our current environment, there are a lot of factors that go into accessing reproductive health care, especially for the disability community, where my work mostly focuses on. Since Dobbs, this number is constantly changing, but 23 states have either banned or placed hostile restrictions on abortion, and those states represent nearly half of the disabled women of reproductive age in the US. And many of these states that significantly restrict abortion access are parts of the country where there are disproportionately higher percentages of Black, Hispanic, and Indigenous community, as well as higher rates of poverty. So this creates a disproportionate impact of people of many different marginalized identities. People with disabilities are at heightened risk for obstetric emergencies, even though people with disabilities are just as likely to experience similar fertility desires or being sexually active. They're significantly more at risk during pregnancy and face a lot more barriers when trying to access care. And the current legal landscape of criminalization has deterred a lot of people, both from communities of color, people with disabilities, people from low-income communities from trying to access life-saving reproductive health care because of these threats of criminalization. So there are 4 barriers that we see regularly come up for especially the disability community, but for lots of different communities when trying to access reproductive health care. And that includes socioeconomic barriers. So people with disabilities, for example, are twice as likely to live below the federal poverty line and are significantly more likely to be on Medicaid to both receive their healthcare services, but also to receive community care services that allow them to live in the community and outside of institutions. So when there are threats to that type of access, that not only affects people's ability to get into a clinic to see a provider, but also impacts the support services that they need to live their daily life, access transportation, access other services like food or like home-based care. Logistical barriers are significant. We know that people are having to travel a lot more often and at further different distances to receive reproductive health care. And those barriers can be particularly difficult for someone who might rely on a caretaker for transportation or have difficulty accessing privacy because of their living situation or having family members or caretakers when they have to access their health care. And reproductive health care, as we know, is something that is particularly sensitive to privacy concerns. Health system barriers are also a big issue as far as people on Medicaid. So a lot of healthcare funding agencies don't conduct oversight to ensure the Americans with Disabilities Act compliance, and they don't usually assess healthcare providers' disability cultural competence. There are also structural barriers in the way that the federal insurance programs like Medicare and Medicaid are structured. So there are people with disabilities who are on Medicare because of their eligibility as a person with a disability, and there is Medicare Type B that does not cover contraception for the sole purpose of preventing pregnancy. And other Medicare plans like Part D only cover some types of contraception, as well as the Hyde Amendment, which we touched on, that doesn't allow for Medicaid to cover abortion care except under very strict circumstances. And then even if someone can overcome all of these intersecting barriers and actually get to a clinic, there's still issues like inaccessible facilities, inaccessible medical equipment, and further training that providers might need to provide equitable care for people of color or for people with disabilities.
Thank you so much for walking us through sort of the overview of what we're looking at. And just for, I just had a clarifying question. When you're speaking of increased threat of criminalization, are you talking about increased threat of criminalization of abortion care, of immigration status, something else, or all the above?
I think all of the above. I think that a lot of people are really concerned about both the intersections of things like immigration status when trying to access care, and also just the increased criminalization of pregnancy outcomes that have been an upward trend even before the Dobbs decision.
Absolutely. Yeah. And that's totally fair. I assume that unfortunately was the case, that it was all of those issues combined. But yeah, thank you for clarifying. Can you dive a little bit deeper into how attacks on healthcare funding specifically further contribute to the healthcare inequities that you've already outlined, such as care deserts, the inaccessibility, et cetera?
Yeah, absolutely. So these attacks on defunding Medicaid and healthcare access more broadly, like family planning clinics, are a huge blow for people trying to access care. Like I mentioned, Medicaid does not just cover like your standard appointment to like your primary care doctor. For a lot of people, it's covering their in-home care, so having someone come to their home so that they can avoid institutionalization to provide supports. It also can cover in some states, it might cover things like transportation to their medical services. And because people with disabilities, people of color, et cetera, are living below the federal poverty line, quite often having access to low-cost family planning services is critical in order to maintain bodily autonomy. So when we have these care deserts that are created by both the restriction of abortion access, as we see in states like Idaho, for example, but have had a significant increase in their care, in the availability of like obstetric care, those issues are only compounded as Medicaid is critical for keeping a lot of these rural hospital facilities open. And without those funds, people that are in these more rural areas might have to travel significant distances to be able to access care. And in a medical emergency, that can be the difference between life and death.
Wow. That's really frightening stuff. Thank you for breaking that down for us. My final question for you at the moment is, how can abortion and reproductive care providers best support their patients right now in this political moment?
Yeah, absolutely. So I think that this is a very scary moment for all of us, and that can feel really overwhelming. But like for providers in particular, I think trying to focus on continuing to provide really quality care experiences for your patients that are accessible and are informed by all of these competing barriers that people might be experiencing is critical. Um, we just actually recently released a report called Lessons from the Disability and Abortion Access Survey, Responses and Recommendations, where we did a survey of disability community members who have tried to access reproductive health care and in particular abortion care across the country, and their experiences as far as things that were difficult when trying to access their care and the things that were positive from their care experience that they think that other providers should implement. So that can include things like readily accessible medical practices, like ensuring that staff are trained on how to work with patients with disabilities, like using the accessible medical equipment that might be in their office, how to provide plain language explanations of their care. And so when we talk about plain language, we're talking about things that are between like a 5th and 8th grade reading level, which is helpful not just for people of all sorts of disability and access needs, but also helpful for people who English might not be their primary language. And also making sure that your staff are trained on how to set up accommodations and what their obligations are under rules like Section 504 and the ADA. And being able to provide information about like what sort of accommodations are available at your facility on your website, or making sure that you're clear on what the rights of your disabled clients are, having that posted, and screening patients or clients for their access needs when you're doing their scheduling and initial intake can allow the process to be seamless for their clients throughout their whole care experience. So that way clients don't have to repeatedly make the same accommodation requests over and over again at the same facility. And that can really kind of streamline and take some of the stress out of what can sometimes be a very stressful experience to go to the doctor and be trying to access things like abortion care or other forms of reproductive health care. Making sure that you have effective communication set up, and training on supporting the medical decision-making capacity of clients, always coming from a place of assuming that people are capable and able to make the best decisions about themselves, like their own bodies, and what care is best for them when they have the proper support of full information and informed consent. And then being able to connect their clients with local community resources. So whether that's connecting clients with abortion funds that might be able to help fund their procedure or help with some of the logistical barriers of accessing their care, or being connected with other community resources that you can refer your clients to, like local disability organizations or other types of care that or community supports that can also be really helpful for providers to just have those resources ready and on hand to share with clients. I cover a lot more recommendations in our report. I'm happy to drop it in the chat if that's okay. But those are just some of like the top line ways that providers can try and support clients during this time.
Absolutely. Yes, please do drop it in the chat. That was going to be my quick question to you, where folks can find the information before we go to the next panelist. So thank you so much for that. And everyone, please check that out. I know I will after this. Cool. Thank you so much, Amanda. Looking forward to hearing more from you during the Q&A section. If you have questions for Amanda or any of the other panelists, shoot them in the chat box. But yeah, we will head on over to our next panelist. And I will pass it. Thank you so much. I will pass it over to Ani to introduce.
I am really excited to introduce Kat Duffy. Kat, thank you so much for joining us today.
Sorry, it took a second to unmute myself. Thank you so much for having me. I'm really excited to be here.
Of course. So Kat is the policy analyst at the National Health Law Program, or NHELP, where she leads the organization's work on insurance coverage of abortion with a particular focus on Medicaid and the ACA marketplaces. Her portfolio includes supporting state advocates nationwide in their efforts to improve and expand abortion coverage and leading NHELP's federal legislative and administrative abortion advocacy. Kat is a nationally recognized expert on Medicaid coverage of telehealth medication abortion service delivery and has written extensively on how states can improve access for Medicaid enrollees. Before joining NHELP, Kat worked at Planned Parenthood Federation of America, where she supported the creation of advocacy strategies to protect and expand abortion access across the country. Kat completed her PhD at the University of Southern California's Annenberg School for Communication and Journalism. Her health policy research agenda focused on issues related to the Affordable Care Act, contraceptive coverage, and Medicaid. I am super excited to hear Kat's answers to some of these questions. And I am excited to dive into our first question. Kat, what are some specific facets of either HR 1 or the Medina versus Planned Parenthood South Atlantic decision that we should be paying attention to right now, specifically in the context of reproductive care?
Yeah, so first I'll tackle HR 1 and then Medina, since they're sort of a 1-2 punch when it comes to harming sexual and reproductive healthcare access, especially for Medicaid enrollees. So HR 1 both specifically targets abortion access and contains major cuts to Medicaid overall that will harm access to sexual and reproductive healthcare. So as you explained earlier, the final bill included the abortion provider defund, which blocks certain providers from receiving any payments from the state Medicaid agency that include federal funding for a 1-year period. And while the bill targets Planned Parenthood, it also affects any independent abortion provider that meets those 4 criteria, and several at minimum have identified themselves as qualifying. So we won't know the immediate exact scope of impact as there's litigation ongoing to challenge this provision, but if it's implemented as is, it will likely force countless providers across the country to have to close their doors. And in many communities, abortion providers are the only affordable provider with expertise in sexual and reproductive health. Blocking Medicaid enrollees from getting care at these providers will weaken the US healthcare system and deepen our maternal health crisis, particularly in rural communities and medically underserved areas. Sort of zooming out for a second, HR 1 cuts nearly $1 trillion from Medicaid. And when faced with the loss of millions of dollars in federal funding, states are going to be forced to scale back eligibility standards or cut coverage for optional services. And given the increasingly stigmatized and siloed nature of SRH services, it could be a huge target. States might lower their income eligibility threshold for pregnancy-related Medicaid or drop critical optional programs such as limited scope family planning coverage, which could cause millions of people to lose coverage. States might also consider narrowing the scope of pregnancy-related services that are covered, or walking back state-funded programs like the ones that provide abortion coverage. And beyond these funding cuts, HR 1 imposes punitive new barriers like work requirements and more frequent eligibility checks that make it harder to get and keep coverage. And we know that insurance coverage is one of the most crucial factors in ensuring equitable access to abortion. When people don't have coverage, it forces them to pay out of pocket for their care, and those are costs that they might not be able to afford. This is particularly true for Medicaid beneficiaries who are ill-equipped to deal with the unexpected high out-of-pocket costs associated with abortion and some other SRH services. Switching over to the Supreme Court, as you explained, the question presented in Medina centered on whether or not the Medicaid free choice of provider provision unambiguously confers a right upon Medicaid enrollees to choose a specific provider. And the Supreme Court found that it does not confer that right, which weakens the legal protections that allow people to challenge harmful state policies that cut off access to care. This decision allows South Carolina to kick abortion providers out of the Medicaid program and will jeopardize the availability of critical sexual and reproductive health care services. And if other states follow suit in removing abortion providers from their state Medicaid programs, it's going to have immense effects, worsening barriers to care, increasing health inequities, and escalating the already dire abortion access crisis. And you have to sort of situate this decision as a part of the broader sustained attack over the last several decades that seeks to undermine and eliminate access to sexual and reproductive health care services. HR 1's abortion provider defund and the attacks we've seen from this administration on Title X funding are just a few recent examples. And due to these attacks and provider shortages, other Medicaid providers can't absorb the affected patients, meaning that many Medicaid enrollees will not be able to receive care because they have nowhere to safely access these reproductive health care services. So as I said earlier, these are sort of like a devastating 1-2 punch when it comes to access to SRH services in Medicaid.
Absolutely. And thank you so much for breaking that down in a way that is so digestible. I know that these are pretty large and sometimes nebulous seeming legislation, and thank you for making that more accessible. My second question for you is, will a tax on Medicaid impact folks seeking medication abortion care through telehealth? And if so, what will that look like?
Yeah. So first, I just want to briefly level set on Medicaid telehealth abortion or TMAB access and what that landscape looks like. So as you explained, Medicaid enrollees' access to abortion has long been limited by the Hyde Amendment, but states can and do use their own funding to provide abortion coverage to Medicaid enrollees, and there are 19 states that do so. When it comes to telehealth, there's no federal requirement in Medicaid around telehealth coverage. In fact, the Medicaid statute doesn't recognize it as a distinct service. So states have wide latitude in determining coverage, including how to define telehealth, what services are covered, what modalities are covered, and which providers can deliver services via telehealth. As is true for much of Medicaid, the scope of coverage for telehealth medication abortion varies widely depending on the state. Generally, Medicaid coverage of TMAB has improved significantly since the COVID-19 pandemic caused, the telehealth revolution. And states have established more robust coverage of the full spectrum of telehealth modalities, improved payment parity policies, and removed some restrictions around definitions of sites of care and how to create a patient-provider relationship. But there remain significant barriers, including gaps around coverage of asynchronous care and other restrictions. And HELP has done a lot of research on this landscape, and there are 3 different reports on our website that are, deep dives into what this landscape looks like. In terms of access threats, HR 1 takes a sledgehammer to Medicaid in many ways, but it makes no changes to coverage policies when it comes to telehealth. But it is worth noting that the added stress to the abortion provider network caused by this bill and the major coverage losses that we anticipate will likely make it harder for Medicaid enrollees to access abortion full stop, whether that's in person or via telehealth.
It's so insightful, especially as you said, we're in this kind of telehealth revolution. People are self-managing their abortions now more than ever. And so it's really useful to know how it may or may not be impacted. My final question for you right now is, what are some differences we should be paying attention to between Medicaid expansion states and those that haven't expanded Medicaid in the context of reproductive care, especially looking at HR 1?
Yeah, the data is really clear that Medicaid expansion has been crucial in the fight against the maternal mortality crisis. Medicaid expansion has increased to prenatal and postpartum care as it tangibly increased coverage rates both prior to and during pregnancy. Studies have shown that these coverage expansions have been essential to increasing access to healthcare for pregnant and postpartum people, including evidence of increased utilization of prenatal and postpartum care. The importance of Medicaid expansion in combating the maternal mortality crisis makes the provisions in HR 1 that specifically target and effectively punish expansion states particularly problematic. Many of the financing cuts are substantially harsher for expansion states, including the changes that were made to provider taxes and state-directed payments. The reconciliation bill also ends the increased federal medical assistance percentage or FMAP incentive, which was a short-term increase to the amount of a state's Medicaid costs that the federal government reimburses for the expansion population. This sunsets starting next year, which effectively eliminates the incentive for the remaining 10 holdout states to implement the expansion, which leaves nearly 2.9 million adults who could gain eligibility under the expansion uninsured. And faced with such major funding cuts, in addition to all the other increased administrative costs around implementing the new work requirements and increased eligibility checks, some states might be forced to consider rolling back the expansion altogether, which would worsen the coverage losses and undo potentially a lot of the gains that we've seen in access to sexual and reproductive health care and combating the maternal mortality crisis.
Oh, yes. How worrisome that is. Kat, thank you so much for your thoroughness and your expertise on this rather dense subject. And I will pass it back to Jessica to introduce our final panelist.
Thank you so much, Ani and Kat. I really appreciate it. So it is my pleasure to introduce our next and final panelist. Mia Eves-Rubli is the Senior Director for the Disability Justice Initiative at American Progress. Prior to coming to American Progress, she advocated for disability justice and inclusion at nonprofit organizations and businesses across the United States. She has worked with Women's March, Families Belong Together, DC Action Lab, Adoptees for Justice, Fair Fight, People's Collective for Justice and Liberation, and numerous other progressive organizations. Best known for founding the Women's March Disability Caucus, Eves-Rubli helped organize the original Women's March in 2017 in Washington. The Women's March was one of the first large-scale events to have certified deaf interpreters on stage. Eves-Rubli's work pushed for better access to disability accommodations at progressive events and more policy platforms inclusive of the disability community. For her work on the Women's March, Eves-Rubli was named by Glamour magazine as one of 2017's Women of the Year award. She was also recognized by She the People as one of 20 women of color in politics to watch in 2020 and was awarded the 2019 Distinguished Alumni Award from the University of North Carolina School of Social Work. Eves-Rubli worked on several political campaigns during the 2020 cycles as a North Carolina Community Regional Organizing Director for the Elizabeth Warren Campaign for President. She communicated policies and organized events around specific issues affecting disability and Asian American communities. She volunteered on Warren's Disability Policy Group, helped shape the Disability Policy Platform, and developed the campaign's private event accessibility toolkit. During the general election, Eves-Rubli worked as the field director for Down Home NC to encourage rural residents to vote. Mia, thank you so much for joining us today.
Thank you for having me.
Wonderful. My first question for you, can you speak specifically on how the new work requirements for Medicaid enrollees included in the budget bill will affect people's ability to access care?
Yeah, so there's a few new components that the HR 1 put into action that will sort of get started after the next midterm election. And these include things like what they like to call is work requirements, but it's really paperwork requirements, and then multiple every 6 months a review of your eligibilities and confirmation of wherever you're living to ensure that you live in the state that you say that you are. So all of these, what we call administrative burdens, are going to actually impact, in particular, disabled people, including disabled women and people who can become pregnant. And so this is extremely concerning as the, we've seen a lot of people talking about how the cuts to Medicaid won't impact disabled people, but the problem is that a lot of politicians don't understand who is included in the disability community, that a lot of individuals aren't able to get that designation of disability, which is a higher standard under Medicaid than under the Americans with Disabilities Act, which just turned 35. So, what Medicaid is using would be something like, is the individual eligible for Medicaid or Medicare based on their disability? Are they disabled due to being qualifying as disabled through the VA? Do they have the paperwork that shows that they are specifically disabled? A lot of disabled people can't get through those processes because of the administrative burdens just to get through those, So we're talking about a population of individuals who are going to still count as disabled, who are going to be required to do these paperwork requirements to show that they are working. And one thing I want to really point out is that 70% of individuals who are on Medicaid are working. A majority of those who are not working are either not working because they have a disability or are taking care of somebody that either is a child or an adult that has a disability. And then we're looking at a very, very tiny proportion of people who would technically fall under is an adult that does not have a disability. And one of the interesting things that we found when doing some of the research that we have been doing over the last month is that these requirements, these check-ins, these paperwork requirements all cost a significant amount of money. The states being able to administer these are extremely difficult. And so one of the things that we saw, you know, Georgia tried to have a expansion program that that people had to prove that they were working in order to be able to get Medicaid. And what they found was that they were wasting so much money on overhead costs. They had spent, you know, millions of dollars on overhead costs, and it was causing significant issues where they weren't able to sign up people in the amount of time that they had said they would be able to sign them up. That the case managers on the ground weren't able to keep up with being able to check in with folks every month to see if they are working, and they even had difficulty doing it every 6 months. So, you know, there's significant amount of work that goes into trying to develop a way to implement HR 1 policies for Medicaid.
Yeah, absolutely. That seems to be, when I've been following this story, just through mainstream news, the general consensus of it's just going to be not on top of the difficulties that folks are going to have to navigate, just an administrative nightmare that just sort of the infrastructure is not there. So thank you for walking our audience through that. My next question for you is there a pathway to expanding Medicaid within the constricts of the constrictions of recent and ongoing attacks on the program?
So there are a couple of things that folks can sort of do in terms of addressing the Medicaid concerns. I think when people are misconstruing how the cuts will happen in their states. It's not actually the federal government literally cutting funds. What they are doing is actually cutting eligibility, which will eventually impact the funds that go to states, because those funds don't just go to a specific service. Those funds go to that hospital, and those funds get utilized in a multitude of ways, including paying for wages, paying for equipment, paying for the building, and paying for a lot of other things. And so when you have fewer people who are eligible under Medicaid, that is going to eventually lead to states receiving less funding, hospitals receiving less funding overall, which is what causes these massive cuts, because the states have to maintain a balanced budget. And what they are doing is basically they are going to have to look at either the eligibility requirements in their state or look at optional benefits, which can often include prenatal stuff. It can include home and community-based services. It can include a lot of different services that individuals who are trying to get reproductive health care, it can impact them significantly. So one of the things that people can do within their own states is the state legislators right now are looking at their budgets because they're going to have to keep a balanced budget through next year. And then when the cuts really impact them, they're going to have to look and see where their money is going and figure out where they can cut in order to be able to maintain that balanced budget. And what you can do as an individual is talk to folks, really talk to state legislators and talk about the importance of the program and why they shouldn't be cutting services within the Medicaid program, in particular around reproductive health care access.
Great, thank you so much for that answer. My final question for you at the moment is, what are some examples of how we can achieve equitable health care beyond or outside of Medicaid? And you mentioned calling reps for, in those states in which they will be voting on it. Are there any other steps that folks can do today?
Yeah, I think, there's been calls to really push for a real overhaul of the way that we provide healthcare in the United States. And I know a lot of people have heard of things like, expanding Medicare, expanding Medicaid, all of these other ways that we can do it, and just understanding how these federal services really keep services open for the most marginalized communities, including in rural areas. And so some of the things that we need to continue to talk about is how can we make our healthcare system, how can we boost our structures? How can we ensure that they have the funding that they need? And one of the ways that we have been really fiddling with is how can we ensure that Medicare covers more of these costs? Because there's a lot of disabled people who are on Medicare but can't receive reproductive health care services because they're not covered under Medicare. Medicare was created for older folks, and so they were like, well, why would we cover reproductive health care issues? Well, we now really need it to cover reproductive health care issues because disabled younger individuals are on Medicare now and require those services. And so many of those individuals have to go into significant debt or sell all their assets in order to be able to become eligible for Medicaid so that they can get those services. So really understanding, I think it's really important for individuals to understand how their state manages these programs and figuring out ways to ensure that their representatives really back these programs.
Absolutely. Mia, thank you so much for walking us through your breadth of knowledge on this topic. If anybody has questions for Mia or the other panelists, please enter them in. Thank you so much, Mia. All right, I will go ahead and just note that you can plug into future reproaction campaigns at www.reproaction.org. You can follow us on social media at reproaction. And save the date for our next webinar. That is Care Outside of the Medical System. That's going to take place on Tuesday, August 19th at noon Eastern Standard Time. Okay, so we'll get into the Q&A section. So my first question is actually back to you, Mia. So as I mentioned, when hearing discussions on Medicaid cuts and the recent bill that passed, I'm seeing a lot of discussions on the requirements to people submit that they are working. And as you highlighted before, the majority of folks who are on Medicaid are in fact working. Was this type of conservative talking point trying to frame folks with disabilities or who are on Medicaid as non-working folks a common talking point before this year?
So I will say that in general, it's a common talking point. I think that it's become more of one just because they really wanted to make cuts on Medicaid and they didn't want to seem like they were soulless and cutting services for disabled people or mothers or children. And so they really kind of went back to the sort of welfare queen sort of uh, talking points that were around SNAP programs and TANF programs in order to try to get people to be like, well, of course we want to cut these people off. They're not working, without really seriously looking at one, majority of them are working, and then two, there's no way to ensure that every single disabled person is able to get those services because disability is such it shows up in such different ways.
Absolutely. Thank you so much for noting that. That has been something that I've been curious about as well. So thank you, Mia. My next question is for Kat, and that is, what are some misconceptions that folks have around telehealth and that you would like to dispel?
Yeah, this is such a good question. I think that there's still a lot of stigma associated with telehealth and the idea that it's not, quote unquote, real healthcare unless you're talking to a doctor face to face. And I think the best sort of illustration of this is the degree to which coverage for asynchronous telehealth, which is, the telehealth model where you're not having a real-time interaction with a provider, lag so far behind synchronous telehealth, or the fact that it took, the pandemic and like a real reckoning around the access requirements for audio video telehealth for there to be improvements in coverage of audio only synchronous modalities, because people, when they're thinking of telehealth, are thinking of like, you pull up the video call with a provider and have that sort of interaction, but there's actually a bunch of different service delivery models that patients can and should be able to choose depending on their needs, their comfort level, and how they want to receive care. I think that's particularly important in the context of sexual and reproductive health care and abortion, because to have a synchronous interaction with a provider, even if it's audio only, it assumes that you have a safe place to, conduct the phone call. You have the ability to take time out of your day to have a synchronous interaction with a provider that's often determined by the provider's schedule and not yours. And for many people, their home isn't necessarily a safe place to have a phone call about, needing an abortion, or folks might not be able to take time off of work in order to have that synchronous interaction. And so at NHelp, we've done a lot of work to do education around like what different telehealth service models look like and why robust coverage of all of them is so important for facilitating equitable access to, not just abortion, but, the full spectrum of sexual and reproductive healthcare services.
Awesome. Thank you so much, Kat, for walking through that. As someone who has personally benefited from telehealth appointments, I really appreciated it. Cool. And my next question is for Amanda. So thank you for sharing the lessons of disability and abortion access that has been posted in the chat. I wanted to ask, are there other top takeaways that you haven't already shared with us, or any surprises that you found from that survey?
Yeah, I'd be happy to talk through some of the other takeaways we received from the survey. I think one of the more surprising themes that I received from the survey is we tried to be really holistic in what we talked or how we framed like abortion services. So we asked questions not just about like their experience, like having like a telehealth abortion or going to a clinic and having an in-person appointment with an abortion provider, but also things like interacting with like an abortion doula or an abortion fund. And we had a decent amount of responses that either worked with an abortion doula or support person or navigator in some form during their abortion experience, but we didn't actually receive any responses of people who received support from an abortion fund, which I found kind of surprising. So we had a limited sample size, so I'd love for there to be more research in the future around accessing abortion care for the disability community. But I'm not sure if that gap was maybe just a reflection of a lack of awareness of some people and their local abortion funds and resources that they might have available, or if it's reflective of like a bigger gap in providing accessible abortion fund services that I'd love to explore in the future. Because I think abortion funds are particularly well situated to be providing accessible services and bridging that gap. Abortion funds do amazing work to work through the logistical issues of accessing abortion for all of their clients facing like a variety of barriers. And I think that they're a very important key part of the landscape of accessing reproductive health care, and they do amazing work. Some of the other like main reoccurring themes that we got in our survey responses that I didn't find as surprising, but were still like very important to hear about were almost everybody talked about why having abortion access was so important to them, as far as reinforcing their sense of bodily autonomy, making them feel like they had control over their life and their choices, but also how they were at a point in their life where they didn't have access to the resources or support to be a parent at that time, including for a lot of reasons that had to do with the higher support needs that they had as being a person with a disability and feeling like they didn't have the support to also be a parent. As well as we heard a lot from people about the health risks associated with pregnancy as playing into their decision to receive or pursue an abortion, and themes of negative experiences that some people had with providers having bias or stigma around disability and their ability to make informed decisions, or some preconceived notions about like the sex life of people with disabilities and being sexually active and having partners in their life. So maybe not always receiving comprehensive sex education prior to trying to access care. And then for our recommendations that we pulled, we separated them into two categories. So practice recommendations were things that providers, abortion support staff, abortion funds could all implement around those things that I talked about, like accessible practices. And then the second portion was also around key advocacy recommendations that advocates can incorporate into their reproductive rights work to make sure that they're being inclusive of the disability community. And the top one for that was around advocating for expanded access to community services and expanding Medicaid to support people with disabilities to work and live in their community and having a living wage. Supporting the end of forced sterilization, highlighting the danger that abortion bans have, particularly for people in the disability community. Abortion storytelling is such a key way that the movement is able to change minds and narratives around abortion, but making sure that that abortion storytelling efforts also include the stories of disabled people. And also just promoting research and collection on access to reproductive health care for disabled clients. A lot of times, there's a lot of really great research around reproductive health care out there for people of color or from different socioeconomic backgrounds, but a lot of times they don't include the demographic of disability within their research demographics. So it's very difficult to then use those same conclusions to also talk about how disability is playing into what's happening on the ground and being able to form evidence-informed policy decisions that can address the needs of people with disability when we don't always have the research that is looking specifically at disability status as a factor.
Absolutely. Thank you so much for walking through some of those findings and perhaps future areas of topics that the surveys can get into. Thank you so much to Amanda, Kat, and Mia for sharing your expertise with our audience. And thank you so much to Ani, my co-host, for organizing this month's webinar. Appreciate you all, and I hope you have a wonderful rest of your day. Take care, everybody. Bye.
Thank you.
Thank you.